Welcome back. I would now like to introduce Karbeah, who will be presenting on the impact that historical and structural racism has on adolescent health outcomes. As a reminder, you can enter questions in the chat throughout the presentation. Karbeah is a Ph.D. candidate in the University of Minnesota School of Public Health's Division of Health Policy Management, studying health services research, policy, and administration. Her focus is on the sociology of illness, JMAG received her MPH in 2017 from the University of Minnesota with an emphasis on maternal and child health. Her research marries her HSR and demography training to analyze the impact of structural racism on maternal and child health inequities. Her scholarship has done this by first examining alternative perinatal care models to address inequities in access and quality that Black birthing people face. And second, by acknowledging and challenging how anti-Black racism is perpetuated through public health and medical institutions. In her dissertation work, she hopes to examine police contact as a form of structural racism impacting adolescent health outcomes.
Hi, thank you for that introduction. I will take a second to share my screen with everyone. All right, we are, as was stated in my introduction, I am Karbeah, and I am a PhD candidate in the School of Public Health at the University of Minnesota. Today, I will build on a little bit what our initial presentation went through and talk about structural racism and child health, both from a general perspective, but also give some practice relevant recommendations that I hope you all feel are fruitful and can discuss going forward. So just a little bit of level setting and intention setting, as Jana talked about at the end of her session. A little bit about myself and how I see the work that I do and where I see this presentation fitting in that larger body of work. I identify as a health equity focused health services researcher, and that is because I have a fundamental belief in social justice, and I'm really committed to creating a more equitable world for everyone, especially children that look like the one pictured here. Today's presentation goes generally into describing the inequities that exist in child health, specifically for Black and Indigenous children. And the work that I do is undergirded by this real commitment to creating a world where these inequities no longer exist, in a world in which we have equal structural access, whether it's to education or to safety for all children, and especially Black and brown children. And I believe that this world is entirely within reach and can specifically be achieved through intentional work by providers and researchers like ourselves and everyone in this room today. Yeah, that being said, I will now jump into kind of my presentation. Yeah. So, racial inequities, racial ethnic disparities in child health, and I'm sure people in this room are familiar with kind of the gambit of it, but generally speaking, when we think about child health, the racial disparities that we see are vast. They are persistent over time. We see very little change over the last 2 decades, and even further when we look at the differences in health outcomes for racial ethnic minority children compared to their white counterparts. And a brief overview of these disparities that I'm sure folks in the room might already be familiar with. In terms of access, we know that Black youth Black children or youth are more likely to report low access to pediatric primary care providers. And even when we control for neighborhood income, we see that neighborhoods with a higher percentage of Black residents are more likely to report limited access to pediatric care. We also know that Black children are 2 times more likely to not have a usual source of care, and are also less likely to report seeing a provider within the past year. In terms of asthma and allergens, we know that Black youth have a high asthma prevalence, high asthma-related hospitalizations and emergency department use. We also know that there are higher rates of dust mite and mold allergen-related sensitivities in this population. We know similarly that for injuries, we have Black and Latinx youth reporting higher rates of firearm injury and other age-related injuries. We see substantial delays in age and timing across multiple immunization categories, as well as higher rates of invasive pneumococcal diseases in this population. When we look at mental and behavioral health issues, we see later age of diagnosis for many. For this population, we also see limited access to mental health specialists, especially for Black youth. And we also see things like later autism spectrum diagnosis in racial ethnic minority children as well. And overall, we see increased mortality rates when compared to the right counterparts from exposures like drowning, but also we see much lower average age of death from congenital diseases than compared to the right counterparts. And similarly, we also see disparities in outcomes, but also access to care in terms of nephrology, weight management and obesity, ophthalmology, and also orthopedic issues within this population. So that's a very long list of disparities that we know exist from the research literature. But I think before going forward, this was kind of touched on by Jana, but it's really important for us to name what we're talking about when we talk about disparities in health and disparities in health outcomes, especially for adolescents. We know that when we talk about a disparity, we're talking about just a difference between 2 groups, and this difference is not necessarily a value-laden difference, so it's just a natural occurrence. But when we think about specifically health and healthcare, it's more important for us to think about these differences in patient populations in terms of inequities rather than disparities, because we know that inequities often arise due to failures of our social structure and are a consequence of unjust resource allocation within our society. And why it's important to think about the aforementioned disparities as inequities rather than simple disparities is that we fundamentally know that Black and Latinx children are not physiologically different. They are not biologically different. They're not genetically different from their white counterparts. So we must ask ourselves what systems are at play within our society that cause these discrepancies that we see in disease incidence, but also disease outcome. And it's really important for us to interrogate our ideas of race. As was briefly stated earlier, we know that there is no genetic or biological evidence of what we see as race, especially especially in the US, a society that's so focused on race and racial identity. But we know this is more of a phenotypic descriptor than it is a true descriptor of biological difference or genetic difference. And kind of going to Jana's point, it's important for us to all be intentional and do a little bit of level setting here when we talk about race. And some of this might be repetitive for folks, but I think it's really important for us to take a brief moment to really interrogate what lessons we've learned about race and racial identity that rely more on this social construction of race and really attempt to make us falsely believe that there is a biological basis between the phenotypic appearance that we see. And the example I like to use, because when I started doing this work about a decade ago, there was a lot of discussion, especially among physicians and medical students, where I spent a lot of my work around notions of race-based diseases, right? And race-based conditions such as sickle cell anemia. So we all know that within the US, individuals of African descent are overwhelmingly those who have sickle cell anemia. And also when we look globally, we see similarly across the world that it is individuals who have some shared genetic ancestry from those, some shared African ancestry in the US who have sickle cell. And this is also evident when we look at rates of sickle cell anemia on the African continent. But also when we take a broader global look, we also see that maybe it's not this phenotypic identity that explains the rates of sickle cell anemia that we see, because we also see relatively high incidences in places like Egypt and Saudi Arabia, and especially on the Indian subcontinent. So taking a step back, we can say, well, based on this map and the incidence of sickle cell anemia, we know that it's not exclusively people who we would racialize as Black who are impacted by this disease. So it calls into question the education that many healthcare professionals receive that sickle cell is a Black disease, because we see, traditionally speaking, very few of us in this room would racialize folks from the Indian subcontinent as Black. So when we think more broadly about why we see a higher incidence of sickle cell anemia in people who are phenotypically categorized as Black, it's important for us to take a larger evolutionary perspective to this. And we see that the distribution of the sickle cell also matches somewhat perfectly with what we see as the global distribution of malaria. And so when we think about the previous map that we saw along with this, we can really think more critically about which patient populations present with sickle cell. And instead of concluding that it is a race-based disease, we see instead that sickle cell anemia, specifically the mutation that causes sickle cell anemia, has been closely linked to ancestral exposure to malaria. And we know from some studies that the sickle cell anemia gene might confer some biological protection to contracting malaria. And that's why we see it so prevalent within this population that is within the malarial zones. And in the US, due to our history of chattel slavery, we see that specifically in Americans who have a history, who have African ancestry. Right, so that's some background. I think it's really important to be sure we're all on the same page, and it's really easy to fall into these ingrained patterns and what we've learned through medical education and other forms about, well, race is a social construct, but we can still point to things that are only in certain racial groups. Instead of this being a race-linked thing, we see that this is a result of genetic ancestry, and I think it's important to do that level setting and to continually, throughout this presentation, interrogate what race really means and how race presents itself in our work. But in addition to this, we also know that outside of sickle cell anemia, we do see very real inequities in terms of outcomes within people who are phenotypically categorized as Black in our country. And I present right now, there are two graphs on the screen showing the differences in age-adjusted mortality and life expectancy between Black and white Americans from 1900 to 2020. And what we see in these graphs is that at no point in the last 120 years have folks racialized as Black in the US had the same health outcomes as those who have been racialized as white. And I just spent a lot of time being very academic and exploring sickle cell anemia and telling you that race is not a biological fact. So how do we explain away these inequities and disparities that we see in life expectancy and mortality? And I think this difference is best captured by the sociologist W.E.B. Du Bois, who in the late 19th century said, the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation towards the well-being of the race. There have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference. And with that quote, along with these graphs, I say we see these continued inequities due to intentional neglect of individuals racialized as Black in our society. This is the direct result of structures and policies that disregard the health and well-being of Black people. And fundamentally, these policies are undergirded by a belief that Black people are less deserving, deserving of resources, deserving of opportunity, and honestly deserving of respect in our country. And this belief and these policies are what we understand to be racism, and what we see are the impacts of racism that cause these disparate health outcomes. So this is the definition that we all saw earlier, folks who were here for the earlier session from Jana. This is from Dr. Kamara Jones, who refers to racism as a system of structuring opportunity and assigning value based on social interpretation of how an individual looks, so phenotypic identity, that unfairly disadvantages other individuals and communities and saps the strength of the whole society through a waste of human resources. And traditionally speaking, we think about racism operating on 3 levels. So the interpersonal, so this I term old-fashioned racism. So this is the racism that we have been taught socially to have this visceral response to. So this is KKK racism, right? Disturbing language from one person to another person, interactions that are tinged with hatred or prejudice due to an individual's race. Next, we have this idea of internalized racism. So this is the belief, the internalization of our racial social hierarchy. And this presents itself both in terms of internalized racial inferiority. So this idea that I'm told through media that Black people are bad and not as good as white people. So when I'm seeking services within my community, I am much more likely to travel further distances to seek services from white individuals because I believe they're more qualified and that their products are better quality than those within my own community. But this also presents itself as internalized racial superiority, which is less often discussed. So similar messages being internalized by members of a majority group, and often presents itself. I used to give a workplace example where individuals from a majority group, so white individuals, often feel that they are somehow more qualified to explain concepts or be in communication roles or leadership roles because they've internalized social messaging about their fitness compared to those of their colleagues of color. And of course, lastly, we have structural racism. And in my work, I use the definition put forth by Bailey and colleagues at Harvard, which categorize this notion of structural racism as the totality of ways in which societies foster racial discrimination through mutually reinforcing systems. And so this is multiple social systems, including housing, the criminal legal system, our public health and healthcare systems, our education systems, and banking. And it's important for us to understand when we talk about structural racism, it's insidious and it's difficult to unravel because there's no single actor in place, right? With other things like interpersonal racism, we can point to one person doing a heinous act, right? In the case of the Charlottesville, Virginia riots a few years ago, we could say, oh, here are these people who hold these bad views about people of racial ethnic groups. But with structural racism, what we see are policies that really undergird multiple systems and are not the result of one individual actor, but rather the codification of deeply held social beliefs about Black racial inferiority. So it's really hard to say this one person is bad when you see policies that exist in multiple sectors that explicitly or implicitly support the subjugation of one group or reduce resource allocation from one group because of these deeply held beliefs of Black inferiority. So that's the challenge ahead of us, to think about how we confront something that is so vast and so complex. And thinking from a healthcare perspective, it's very important to make sure that to think about how experiences and exposures to these multiple systems impact health and health outcomes. In my work, I often turn to this conceptual model by David Williams and colleagues that attempts to kind of put together how all these systems are interconnected. And so what we see is that due to basic causes, specifically these institutional exposures that we talk about, so political, legal, economic, cultural exposures, and the interaction with this racial hierarchy that we see directly impact an individual's social status, right? So based on race, gender, SES, you have a certain social position within our society. And through that social position, you have differential exposure to certain risk factors, but also health promoting factors, right? And so we see differential allocation and differential exposure to stress, but also opportunity and resources. And in turn, these differential exposures lead to behavioral responses, but also down the line also result in health inequities, the initial health inequities that we talked about. And so this is a general model, and it's this is usually an adult model and is not adolescent specific, but recent in academic timelines work by Gilbert G. and colleagues kind of better illustrate what this exposure to racism and what the impact of racism looks like across the life course and why it's important to think about adolescence. And G and colleagues, using a life course perspective, really look at 5 main areas in which racism impact adolescent health. So first is this idea of social pathways. So children and youth learn about race in our society very early and are socialized into our racial system from birth. And the socialization happens through multiple institutions. And we know that this racialization happens very early because children as young as 6 months old have been shown to show preferences towards members of their own racial groups and less favorable attitudes toward members of other racial groups. And the socialization happens through media, through education, through the criminal legal system, through all these systems and everyday interactions. Children learn what attitudes are held about their racial groups and what attitudes are held by those around them about other racial groups. So racism, I think there was, I forget the news outlet, but there was a recent story about how early is too early to teach children about race and racism. And we learned that from these studies and these social pathways that children are learning from the second they're born, and it's not an education that happens within schools, and it's not an education that we can really structure for them. It's a passive education, and children, both Black and white children and Latinx children, in their everyday lives are learning how their group and their identity fits within our broader social construct. And small tangent, but that's why it's really important when we think about saving conversations about race. We know that children from historically marginalized backgrounds learn every day that their racial groups are stigmatized and that their identities are not valued within our social system. Additionally, G and colleagues talk about sensitive periods within the life course. So being in a racialized society, again, determines exposures and exposures that can dramatically impact developmental periods and developmental progress. Specifically thinking about the criminal legal system, we know that children and youth of color are more likely to have law enforcement exposure, which increases the risk of criminal legal involvement and potential incarceration, an outcome that we know delays life course transitions. So what does it mean for youth of color to have an increased likelihood of ending up in the criminal legal system or in juvenile detention, which takes them out of school and influences their educational ability and educational outcomes, and thinking about the consequences of that in later life. The third concept is that of linked lives. So we talked about I talked about earlier, these social pathways and how children are constantly learning, but they also learn directly from the experiences of their parents, those in their communities, and their caregivers. And racism and its impacts mean that the experiences of the adults in children's lives also directly impact their lives. So thinking about limited occupational opportunities for adults of color, how that impacts the opportunities that they can then transfer on to their children. Thinking again about the criminal legal system, what it means to have a parent who's incarcerated and what the direct health impacts are on children with incarcerated parents. And then last, thinking about this latency period of racism and exposure to discrimination, and what it means for a child to constantly be exposed to racialized stress, and how that causes both immediate but also delayed stress responses that are then linked to later life adverse health. So what does it mean to live in an elevated stress state because you watch your parents experience these constant interpersonal experiences of racism, or you live in a neighborhood that's less safe because of your race? What does it mean to have these constant stress exposures over the life course, and how that often manifests as increased risk of chronic disease? And lastly is this idea of stress proliferation. So knowing that racialized stress is not singular, and that it's not one instance, but what it means for the stress of living this racialized identity. What does it mean if you watch your parents stopped by the police? You're not, as a child, you're not able to go to school and just stop thinking about that, right? That experience doesn't stop once you're no longer with your parent. That's a stress that then proliferates through every other aspect of your life, and it impacts you that way. So that was a general theoretical overview about how racism becomes embodied and how racism impacts children. And I think it's easy to get lost in this big description of structural racism. Oh, it's from all these systems, and not necessarily give clear direction and description of how interconnected these systems really are in the lives of children. And I think to fully understand how notions of race and policies that are undergirded by these notions have ripple effects throughout the lives of Black and Brown children, it's really important to think about the historical context, and specifically thinking about one institutional exposure and one institutional policy that has ripple effects throughout multiple sectors. Let's take a quick break here. I feel like most of us, maybe once or twice in our lives, have been exposed to this idea of redlining, and it's very easy to just say, oh, yeah, redlining is a really bad thing that happened in the past. But it's really important to understand the consequences of redlining and what it means in terms of health outcomes for youth from historically marginalized backgrounds. So as folks may know, in the US, in the mid-30s, you had the Homeowners Loan Corporation, which was a government agency tasked with encouraging home ownership and home buying in the country as a way to recover from the Great Depression. And what the HOLC did in order to help banks determine lending zones and safe lending and which individuals were more likely to repay housing loans, they created these housing and lending maps and determined which neighborhoods were favorable and which neighborhoods were unfavorable. And this was done through a color-coded system. So you had neighborhoods that were considered good and favorable neighborhoods outlined in green, and progressively those who were considered worse, declining or worse, were outlined in yellow. And finally, you had the worst worst neighborhoods that were outlined in red. And this is where the initial term redlining comes from. But we see from the HLC maps the deep influence of racism, and specifically anti-Black racism in our society, because the neighborhoods who were determined to be good and good lending regions were those that were exclusively white. And the addition of any non-white group resulted in a downgrading of a neighborhood, with neighborhoods that were predominantly minority or predominantly Black being those that were redlined. And the harm of redlining is the immediate, in that we see that it was very difficult for non-white buyers to buy their way into these good neighborhoods. So a crucial part of redlining is that lenders and real estate agents saw that if you wanted to keep a neighborhood good, you couldn't allow anyone who was non-white into your neighborhood. And so this resulted in non-white individuals being relegated to these lower quality neighborhoods and kind of trapped in there, because it was a bit of a catch-22, because you wanted to get your family into a good neighborhood, but having you, a Black resident in that neighborhood, automatically made it bad. So lenders and Black residents often found themselves trapped and relegated to these predominantly minority neighborhoods. And the consequences of this are many, and we see directly huge discrepancies in neighborhood investments based on the quality at which they were rated. And what we saw was increased investment in these good neighborhoods, right? So you had increased school quality, you had infrastructure investment, you had service investment, and also increased proximity to jobs and employment in these well-rated neighborhoods. But what you saw conversely was an intentional disinvestment from these poor quality neighborhoods, right? If these were not good lending regions and these are not determined to be poor neighborhoods overall, why would governments or why would businesses take the time to invest in these neighborhoods? And what you saw was intentional and explicit disinvestment from neighborhoods that were redlined and determined to be majority minority neighborhoods. And this disinvestment is directly linked to the aforementioned disparities in child health outcomes that I started this conversation with. For example, this intentional disinvestment meant that there were differences in zoning ordinances within neighborhoods. And so you see neighborhoods that were outlined as green line or good lending neighborhoods. Those were neighborhoods that governments and residents were very intentional about advocating that these were only zoned for residential use, that the goal of these neighborhoods is to keep them safe, versus political and social disinvestment from redline neighborhoods, which allowed for the placement of industrial zoning much closer to these neighborhoods than in white neighborhoods. So what you see today in many urban areas, Minneapolis included, where I currently am, is that you have neighborhoods that have been historically redlined are much more likely to be in close proximity to factories and other adverse environmental exposures. One specific example here in Minneapolis, the neighborhood of North Minneapolis, which is predominantly African American, is located next to Northern Metals, which is a metal processing plant. And there are obviously considerable health risks associated for not only adults, but children and developing fetuses from being next to this processing plant. We see this in other cities, and this has been directly linked to increased asthma risk in children and youth of color as well. Similarly, in the same line as this zoning issue, we see very disparate allocation of green spaces in neighborhoods that have historically been determined to be green areas and those that are redlined. And we see much lower access to green spaces and health promoting environmental spaces in neighborhoods that have been redlined. And we can obviously see the direct correlation between things like obesity and limited access to green spaces. Here is one study example that shows New York City and its historical redlining districts. And so we see up here are the green, and then we see these red neighborhoods that are predominantly minority neighborhoods. And when we see across multiple indicators, but this specific study looks at child health and preterm birth risk, we see even today a direct correlation between historical redlining and adverse perinatal and child health in these historically redlined communities. It feels a little redundant and repetitive at this point, but I have yet another example of how the direct consequence of redlining and how institutions are interrelated. If anyone here is a homeowner or is an American and understands how we fund education in our system, we know that education is also directly correlated to racial residential segregation. And again, this is because with the disinvestment that we see from historically redlined neighborhoods, this is also directly linked to disinvestments from schools that are in our country funded by property taxes. And because of the concentration of individuals within certain regions, and usually people of the same SES, we see a limited ability of lower income people to create neighborhoods that have higher quality, high investment schools. We know that the US education system is extremely segregated. We know that Black and Latino youth are more likely to attend lower quality schools. They are more likely to go to schools with higher average class sizes, and more likely to attend schools that have law enforcement present and increase the risk of their criminal legal contact. We also know that within these schools, there are glaring disparities in terms of education access and education attainment for youth of color. One study found that where 88% of white youth have high school completion, when we look at youth of color, so it's much lower. So 76% of Black youth, 72% of American Indian youth, and 79% of Hispanic youth complete high school within 4 years. We also see similar disparities in chronic absenteeism, and with Black and brown youth being significantly more likely to be chronically absent from their schools, and to feel supported within these schools as well. Okay, so I think that's a lot of background that you may have heard in popular media about the influence of racism and institutional racism and what that looks like, and structural racism. But today I hope to explore a little bit more about how this fundamental belief, this fundamental system of anti-Black racism results in unequal healthcare and unequal healthcare access. And I think sometimes for providers, it's difficult for us to think about racism operating within the healthcare setting because, well, it's healthcare, it's people who are committed to helping other populations. So it's hard to think about how racism operates within medicine. And I think fundamental to this, again, is going back to our discussions of the various forms of racism. When we talk about racism in medicine, I'm reluctant to say it's not always interpersonal, because there are clear examples of interpersonal racism, but it's also important to think about the structures and the policies and the history that really undergirds racism, and how those policies and practices are truly informed by notions of Black inferiority and white supremacy. So first, thinking about, I think Jana in her presentation mentioned, oh, there's pseudoscience that really undergirds notions of race and white supremacy. But it's important to know that for much of our country's history, we turn to medical providers to justify the subjugation of non-white individuals. And we have used medical science, we have used statistics And we have used medicine to explicitly justify practices aimed at dehumanizing and aimed at exploiting non-white individuals. And this practice began hundreds of years ago, but one example is the science of phrenology, which was the study of head shapes to justify intellect, to justify evolutionary progress. And we saw the use of phrenology in the 19th century and into the 20th century to really support the institution of chattel slavery under the auspice that we see differences in skull shape from those of European heritage and those of African heritage, which suggests that individuals of African descent are less evolutionarily evolved and therefore not as human and not as deserving of respect or equal treatment as their white counterparts, because again, they're a different species of man and therefore deserve a different form of treatment. And so this underlying belief of Black biological and genetic difference really has shaped the course of medicine in various ways and continues to today. For example, these old forms of racism and this belief that Black people are biologically different. A major component of this belief was the idea that Black individuals had a higher pain tolerance. And we see this manifesting itself through various medical professions, but mainly like to draw on the example of J. Marion Sims, who's considered the father of modern gynecology. And Sims, kind of emboldened by this belief that Black people are physiologically different and have higher pain tolerances, was able to conduct multiple dozens of surgeries on enslaved Black women to develop his really transformative procedure on correcting obstetric fistulas. And Sims was able to do this work without giving these women anesthesia, although it was available in the time period because of this deeply held social and professional belief that Black women didn't feel pain in the same way as their white counterparts. After 30 plus surgeries on one enslaved woman, there were a total of 5 documented women who he operated on for 4 years. Sims would then leave Georgia where he was practicing and go north to New York to perform the surgery on white women who he then insisted receive anesthesia. Again, because Black women could tolerate it because they were biologically different, but white women needed anesthetic support for these procedures. So that's one example of how medical practice has really benefited from the belief that Black people are biologically different from their white counterparts. And it's really easy to take a step back and say, oh, well, that was before, and we've moved past these notions of Black biological difference. But we also see similar examples continue today in measurement and medical decision-making. One is that of GFR. We know that there's been recent and very passionate appeals to using race corrections within GFR because the use of race corrections within this measure suggests that there is, again, some biological difference in Black individuals compared to white individuals. And if I want to get more to the adolescent health examples, but there's been wonderful advocacy on this front to change this. We also see similar race corrections used in osteoporotic risk score determination. Again, by assigning additional points to non-white patients, we are implicitly suggesting that there is something biologically different about Black patients that makes them less susceptible to risk than their white counterparts. And so these are some measurement examples, and there has been strong advocacy on this front, but we also see outside of measurement and outside of procedure development, there's also very real demonstrated differences in the quality of patient care that we see Black and white individuals receiving. And what really undergirds a lot of this research and a lot of these findings is we see that many physicians, actually in one study, it was as many as like 50% of providers have deeply held implicit biases against Black patients and in favor of white patients. And these biases and attitudes present themselves in multiple ways. In the systematic review, we find that many providers hold strong implicit pro-white and anti-Black biases. And so these are biases that providers have outside the care setting. These are notions of a fit and capability that providers have been implicitly or explicitly exposed to throughout their lives and throughout their training. We also see these biases in terms of ethnicity with individuals of Hispanic origin, providers showing some anti-Hispanic bias towards individuals of Hispanic origin. We also see differences in attitudes towards individuals based on skin tone, so more preferable attitudes towards individuals with lighter skin tones. We also see differences in terms of perceived patient compliance. So providers are more likely to believe that white patients are more compliant than Black patients. And this is through vignettes where providers were given prompts and asked, which one of these patients do you think is more likely to respond to this treatment course or comply with these recommendations? And they were given pictures of white patients and Black patients with no additional information. So that says, given no additional information other than a patient's race, providers, the majority of providers believe that white patients are more compliant and more cooperative than their Black counterparts. And what this means for patient care and patient quality, we see is that providers who hold these pro-white beliefs or negative implicit attitudes towards patients of color, we see that the care relationship is dramatically impacted with providers who espouse these anti-Black or pro-white beliefs being less equitable in their care setting and being less cooperative when working with patients of color. This has presented itself in what is considered to be more aggressive interactions with patients and less cooperative ones, and patients within these care relationships often report feeling like they've received lower quality care and feeling unsatisfied with their provider interactions. So a lot of this work has been done in adult populations, but upon further examination, we also unfortunately find similar attitudes when we look at pediatric patients. One specific study of pediatric provider recommendations found that within their sample of pediatricians, those with pro-white biases were less likely to recommend narcotic medication after surgical procedures for Black children than those with lower pro-white attitudes. So the pervasiveness of this idea of Black people receiving lower quality care and being seen as more pain tolerant or less deserving of a certain level of compassion and empathy also presents itself in the pediatric care setting as well. And we also see other pediatric examples with children of color being less likely to receive narcotics after long bone fractures upon admission to emergency rooms as well. So that's a lot of information about bias and how structures, but also structures are influenced by anti-Black racism, how medical practice in turn has kind of absorbed these beliefs of anti-Blackness and how it impacts it, not only these external systems, but also the quality of care that individuals receive. So what are practical steps that pediatricians can do after learning about these glaring inequities and disparities in our system? Well, these recommendations come from a recent American Academy of Pediatrics supplement that deals with anti-racism and comes from Maria Trent and colleagues, and is really aimed at addressing practical steps. And some of those recommendations are, one and foremost, to acknowledge that racism impacts all patients. And that means that all patients and all families are impacted by racism, and not only in terms of being victims, but being bystanders and potentially perpetrators of racism, and how clinicians can engage in those conversations, how clinicians can more intentionally create welcoming spaces for all patients. And that's really through examining individual biases and creating systems that ensure highest quality of care to all populations. Also by advocating for initiatives that reduce bias and inequities. I mentioned some previous work that's being done to get rid of race calculations, but also thinking about pediatric care examples is very important. Thinking about in clinical practice, how do we create culturally safe medical homes and medical settings that integrate this fundamental knowledge of racism and its pervasiveness into care? How do we train all clinical staff in culturally competent care, not just providers, but also our administrative staff in culturally competent care? And how do we provide substantive professional support to individuals? We know from thinking about the life course perspective that experiences of racism are not singular, and they often have latent and longitudinal impacts. So how do we provide mental health support to individuals who've been exposed to racism? And how do we develop systems that support young people who are exposed to racism? So thinking about positive youth development approaches that really uplift individuals of color and their racial identity, rather than constantly having them exposed to negative messaging about their identity. And lastly, intentional efforts to develop the pediatric workforce in terms of culturally competent training, but also workforce diversity. I have received a text from Stephanie that it is about time for me to wrap up, but I would like to end where I started. And hopefully I've demonstrated the multitude of ways in which racism and anti-Blackness kind of saps opportunity from children of color in our society, and the vast amount of work that's really needed to create a more just, equitable future in our, and I think this future is possible, and I think everyone in this room is really committed to doing that work. And I look forward to discussing with you all what that future looks like.
Thank you so much for sharing your research with us around how racism impacts adolescent health. We have some questions, so we'll dive right into the Q&A. All right, first question. Are there any externalizing behaviors that health professionals or health educators should be aware of that are particularly present in teenagers as a result of structuralized racism?
Yes, I apologize for not having more references, but there is a nice body of literature that looks at the incidence of depression and anxiety, but also, I think predominantly depression and anxiety in adolescents as a response to experiences of racial discrimination. And there's a few other studies that look at other externalizing behaviors and its direct correlation to experiences of discrimination in adolescents.
Thank you.
Yeah.
How do you see this history of medical racism showing up for Black and Brown adolescents today? And how can we identify and address it as providers or those in public health?
Yeah, a lot of my work, additional work, has also been around the notion of reproductive justice. And I think there is a considerable need to discuss how historical notions of anti-Blackness, and specifically those around reproduction and sexuality, present itself in how we interact with adolescents and how we provide adolescent health care. yeah, and so thinking about how internalized notions of Black promiscuity present in the care setting, I think is an important issue to think about in terms of adolescence.
Great, thanks. Do you have any thoughts specifically on how to successfully outreach about COVID vaccines with the BIPOC communities, given the systemic racism and the mistreatment of these communicated by the medical establishment historically and currently?
Yeah, I think because I'm not a disease epidemiologist, I'm not sure if I'm particularly equipped or qualified to make suggestions around this, but I think there's been wonderful work done by providers like Rhea Boyd around community-informed, community-engaged outreach. A lot of providers have been very intentional about being community-centered, and I think, not to take us too far off a tangent, but I think with vaccine outreach and COVID outreach, we've really seen a lot of racialized attitudes presenting in medical care and medical outreach, specifically ideas of I want to say very harmful ideas about Black intelligence, right? This idea that Black people are unjustified in their apprehension, or this idea that they should simply get on board because the science says so. And thank you, Maria, for sharing that article by Rhea Boyd. And Rhea and other providers have done a lot of work about, these are legitimate concerns. These are people who are asking for more information. These are not people that are saying, I will never be vaccinated. And I think as providers, there's been this a lot of scrutiny on people just not doing the right thing, rather than thinking about concrete ways that we can meet people where they're at and answer the questions they really need answered. And I think as we go forward, it's really important for us to think about how we engage with communities in ways that are not paternalistic.
Absolutely. Any articles or authors that you'd recommend regarding the effects of notion of Black promiscuity and provision of sexual health care conducted by providers to youth of color?
Well, Killing the Black Body by Dorothy Roberts, very broad, but can I get the person's name? Sorry, I'm having a hard time reading the chat, and I can email you a few articles.
Oh, hi. I don't know if I was supposed to answer that. This is Anna Britton.
Okay.
Brittain.
All right. I will try to send you some articles later this week.
Oh, thank you so much. Wonderful.
Yeah.
I would also love some too, if that's okay.
Yeah. Alyssa, I can't see your last name. Could you spell it for me? Oh, yeah. I can just send it to the coordinators. That would be very helpful.
Awesome. Thank you so much.
Okay.
Yes, and we can share this with the whole group. Okay. Any additional questions? Okay.
I have a quick question. I'm sorry. It took me into this is Christine Johnson from Maryland. And I feel like I heard you mention, J-Mag, that you talked about inadvertently about people who are potential perpetrators or perpetrators of bias, how they're also victimized by, the system of racism. Mm-hmm. And it's an interesting frame, because as a Black person, a person of color, I don't generally think of white people as being victimized. I think of them as benefiting from the system directly or even indirectly. But I wonder if you had any thoughts on that, because I think that's worth noting, that people who are, who most people see as the beneficiaries of the system that exists, how they're also victimized by the system. It's not just us people of color who are victimized by it. So any thoughts on that?
Yeah, thanks for bringing that up. That's one of my favorite things to talk about because I feel like we don't spend enough time thinking about it. And I think a lot of there is some comfort, I think, in the traditional framing of race and inequity that often then frames it as a deficit and for people of color, and really fails to see how racism hurts and harms people in the majority group as well. So generally speaking, I think Dr. Kamara Jones's definition really illuminates what is being lost, right? Because we have to think about in our society, where could we be if we didn't limit so many people from achieving what they're capable of? But where could we be economically? Where could we be technologically if we weren't so committed to the subjugation of non-white individuals, right? And it's evading me right now. I think maybe it's Eduardo Bonilla Silva, but there's a lot of sociologists who've written about the deep cost of whiteness, right? You have to really let go of your cultural identity. You have to let go of really everything else to buy into this idea of whiteness and white supremacy, and you lose. There's folks that do labor history and stuff, thinking about what limited gains we've had in labor organizing because it's so easy to split people up based on race rather than class, right? And thinking about the progress that could be made if white individuals were able to ally themselves with all other blue collar workers rather than choosing. A lot of labor concessions have been made with the idea that white laborers are scared of Black laborers getting something that they don't have. And that's really limited a lot of economic progress and also labor progress in our society. So that's one way to think about it. And there's also another really great piece by Jennifer Mallett that theorizes about the health cost of whiteness. And I think there's very limited, yeah, exactly, Dr. Thomas, the Southern strategy, but thinking from Mallett's perspective about the harms that are caused in terms of health by whiteness, especially when we think about things like the deaths of despair conversations we've been having and how those are direct correlates to whiteness and white supremacy. Yeah, I hope that answered your questions, Christine, and wasn't just emphatic rambling.
No, that was awesome. Thank you. And I really appreciate you sharing that viewpoint because I think it's one that people need to hear and it needs to be illuminated and highlighted as well. So thank you so much for all of this.
Yeah.
Thanks so much, JMAG, for all of your work around this. We're going to take a 10-minute break and we will return at 2:05 p.m. Eastern time for a panel presentation featuring unique perspectives on the impacts of racism on specific communities within adolescent health. As a reminder, with any questions or support needed, you can contact us at adolescenthealth@umich.edu. Thank you.